And welcome to today's webinar. My name is Tina Glover, the Life Labs Key Account Manager and Team Lead in BC. And today we have Dr. Romi Fung presenting on Defying Cognitive Decline, Part 2, Applying Biochemical Markers and Case-Based Strategies for Effective Treatment. During today's webinar, should you have any questions, please enter them into the Q&A function at the bottom right-hand side of your screen. And during our remaining 5 minutes, we will try to address any questions as time permits. If we do not get to your questions during that time, please know that we will follow up with each question after the webinar. You can download today's handouts at the top right-hand side of your screen. For attendees that stay on the entire webinar will have a chance to enter to win one of four $25 gift card prizes. At the end of the webinar, you will be redirected to a contest entry page. During the presentation, I will post 3 secret words in the chat. Those that enter the 3 secret words correctly will be entered to win one of 4 gift prizes. Without any further ado, I'd like to introduce you to Dr. Romi Fung.
Thank you so much, Tina, and good morning, everyone. Welcome to part 2 of our Defying Cognitive Decline talks, and I'm honored and appreciative of Life Labs for having me do this. So, with the disclaimer here, the presentation is intended, of course, for educational purposes. Everything does have context and does not replace independent personal judgment. All of these are expressed and solely of me at this time of December 8th, 2025. My name is Dr. Romi Fung, and I practice in Richmond, British Columbia, where my focus is in dementia and Alzheimer's disease. And as you all know, I do take quite the systematic and systems approach, integrative approach when it comes to brain health. And I believe that the brain is more than just doing everything that is to the brain, where I see a lot of people, patients, practitioners, clinicians, and so forth, all thinking, well, if there's something going on in the brain, why not do something about it? Whether that be an insert herb here or an insert supplement there and all that. And not that it's a bad thing, but I like to see that the reflection of the brain, or the health of the brain is reflected on the body. And that's where I started seeing a number of these changes and looking into guiding more and teaching more about understanding how the body is reflected in the brain. So with this part 2, we're going to talk first off briefly review a bit about dementia and the amyloid precursor protein and how we actually look into defining what cognitive decline is, because assessment is going to be very key and important in really guiding you to understanding what kind of tests and lab testing and such that you would have to look into, and what kind of lab tests would be eligible as a result of your findings in the clinic. Then I'm going to talk a bit about the biomarkers, be looking into thyroid, hormones, and a couple of brain health markers in today's lecture. And then I'll be applying not just today's lecture, but also the part 1 that was done 2 years ago, and putting together and showing how these things show up in some of my cases that I see in my practice. So without further ado, let's get started. So, of course, what is dementia? We're always defining dementia, and there's definitely different definitions of dementia. The World Health Organization in 2023 stated that dementia is a syndrome that can be caused by a number of diseases which over time destroy nerve cells and damage to the brain, typically leading to the deterioration in cognitive function, and that includes the ability to process thought beyond what might be expected from the usual consequences of biological or normal aging. While the consciousness is not affected, the impairment in cognitive function is commonly accompanied and occasionally preceded by changes in mood, emotional control, behavior, or motivation. But ultimately, when you think about dementia, before you even think about dementia, you look at the early signs and symptoms that includes most commonly forgetting things or recent events. People are forgetting their wallet, keys, names, faces, or even things that just happened a couple of minutes ago, and these people are looking into and asking about, what just happened. 2 minutes later. So losing and misplacing things, getting lost, and specifically getting lost in familial areas such as one's neighborhood or a mall that they frequent, shopping center, etc. And in these kind of familiar places that they're being confused. Losing track of time. I think we've come to a point where unless if you have habits and activities, time can mean many things in terms of context. Difficulty solving problems or making decisions. Problems following conversations or trouble finding words as though they're on the tip of your tongue. And there's difficulties performing familiar tasks, misjudging distances to objects visually. So especially if your occipital lobe and the cerebellum is not working well, that when they're reaching out for something and you don't really get to that point, then that's definitely an occipital lobe and cerebellar dysfunction. And then the 7 or potentially the 8 A's of dementia that we talked about in part 1. There are many risks, and I'm not going to go through the entire list right here, but of course, age being the uncontrollable risk factor, and there are modifiable risk factors, including hypertension, diabetes, obesity, and so forth, that we need to also investigate in one's cognitive health. So where does this come, and why does this come about? We're always looking into studies of Alzheimer's and treatment of Alzheimer's, and there's some promising, some that are giving us opportunities to really understand about what is going on in the brain. But we're always looking at the hallmark of Alzheimer's disease, being the tau tangles, the intracellular tau tangles, and the extracellular beta amyloid plaque. And in looking at that beta amyloid plaque, truth here is we all make plaque. We all actually make some form of plaque. This image here is just showing 2 main pathways, looking at on the left side here, the non-amyloidogenic pathway, where you have the activity governed by the alpha secretase, cleaving at the alpha site of the amyloid precursor protein, APP. Then you have the right side here, the amyloidogenic protein, amyloidogenic pathway, where the beta secretase is cleaving at the beta site, which then eventually creates this insoluble plaque called beta amyloid. Versus the left side, the non-amyloidogenic pathway, the alpha secretase creates a soluble protein. So we are meant to be making plaque. This is just another diagram right here to show the pathways, and that by creating, cleaving at the alpha site, having the alpha secretase, that you would make this P3, which is soluble. And cleaving at the beta site via the beta secretase is going to create this insoluble protein, now known as beta amyloid plaque. And the plaque, the soluble plaque, is made to make connections and is part of our neuroplasticity. So what is it that's causing our brain to shifting this pathway to go into the amyloidogenic pathways? We look at the BACE1 gene. And by inducing the BACE1 gene, that would then enforce the beta secretase protein to be expressed and created, translated, and thus cleaving at the beta site. So what is inducing this BACE1 gene? And we talked a bit about this in part 1, things like hypoxia, energy disruption, mitochondrial stress, inflammation, and even Alzheimer's disease. So what I mean by Alzheimer's disease is it's a positive feedback loop. When you create insoluble plaque, that will be feedback to the amyloid precursor protein to create even more. So this positive feedback loop, or this kind of vicious cycle of the creation of insoluble beta amyloid plaque, is going to further induce more creation. And thus, the goal here in terms of optimizing one's brain health is not necessarily just to get rid of beta amyloid plaque, but also reduce the induction and the expression of the BACE1 gene so that that cycle does not get enforced. So if this is your first time going through this, I highly invite you or recommend and invite you to refer back to part 1, where I talk about the biochemical factors that induce the BACE1 gene. And that includes things like ferritin and hypoxia, anemia, inflammation, insulin resistance, and so forth. So to continue on and talking about symptomatic cognitive decline, this is where we start looking into mild cognitive impairment. And there is a difference between mild cognitive impairment and dementia. So to define mild cognitive impairment, MCI for short, MCI refers to a cognitive decline that does not significantly impair the cognitive function that then results in affecting the activities of daily living. Now, I think we are all familiar with dementia, the difference between dementia and Alzheimer's disease. Alzheimer's disease is just a form of dementia, and dementia being an umbrella term of encompassing several different cognitive decline and cognitive dysfunctions and syndromes, including Parkinson's dementia, frontal temporal dementia, Lewy body dementia, and so forth. And to define and to assess for mild cognitive impairment, we have access as clinicians to a number of evidence-based clinical objective assessments. You're all probably familiar with the mini mental state exam, the MMSE. And this is a good test to do if you're short on time. Normally this takes about 5 minutes or less. And talking about your orientation, memory, recall, and language. Then there is the Montreal Cognitive Assessment, and amongst the objective tests, the MoCA is the most sensitive test that can be done in the office, in-house. However, it does take about 20-ish minutes depending on how challenged your patients are. And there is the mini-cog, where you're looking at the clock drawing, 3-word recall, and registration. But just going back into the MoCA for a second and to touch base on it, is each one of these tests is going to give you a number. And for the MoCA, it is going to be over out of 30. Just by saying a number out of 30, and normally you would want to be at 26, greater than 26 of 30 to be considered normal for the MoCA testing. When you do get the number, it's always more informative for me to look at what was it that marks were taken off, because what's also good about the MoCA test is that it also shows you the domains that you're testing for. So the first question, connecting the dots with the letters and numbers in an ascending alternating format, and then recreating either a cube or a table and drawing a clock, that's going to test your spatial memory. And that's the back part of the brain right there. Then it also going on to the naming of the animals, that's recognition. So is one apraxic. Looking into short-term memory, looking into arithmetic, language, and even associations. Because whatever I get from my patients when doing the MoCA test, these also initiate things that we could do in terms of stimulation and rehabilitation of your domains of your cognitive health. Also, just to mention here that in order to do the MoCA testing now, the Montreal Cognitive Assessment Association is now asking clinicians to be certified in the MoCA test. It's a 1-hour course, and that will give you not just training for the testing, but also it will give you other versions of the test. And I can actually kind of tell who's actually done the certifications or not, because if I get the same version from the same practitioner, then I know that they haven't gotten access to the other versions there. So FYI right there. But diagnosing mild cognitive decline or mild cognitive impairment and dementia, there's one key point that I think everyone really does need to know, and I emphasize it in bold here, and that is for someone to be with the diagnosis of dementia and or Alzheimer's disease that there must be some significant impairment that causes a significant functional decline in usual activities or work. Now, why do I emphasize this is I do have a number of patients where I have seen in my practice and have seen in my experience where they come in saying that they have been diagnosed with dementia and or Alzheimer's. And I look at them, they came on their own, they're well dressed, they're speaking well, and their language is intact, and they're focusing and having a conversation with me independently. And I would ask, well, how did you get here? Drove here. So there doesn't seem to be a definition that we all know regarding dementia versus mild cognitive impairment. So keynote right here is that the cognitive decline is causing a significant functional decline in usual activities. So these are patients that are unable to bathe themselves, feed themselves, dress themselves, and live on their life independently, and thus are dependent. And that is the same in terms of Alzheimer's disease. Of course, Alzheimer's disease has also the hallmarks of the tau tangles and the beta amyloid plaque. So in going over a number of things when it comes to brain health, I'm always looking at how the body is functioning and how that can then impact the health of the brain. And thus, going over biomarkers is a good way to really emphasize that you're trying to keep the whole body healthy in order to keep the brain healthy. And these things will change even at least a decade before symptoms start to arise. So when working with one that is even for prevention and optimizing their brain health, part one's testing is definitely the start. These tests I will also do in addition to part one and actually see quite significant changes when it comes to optimizing these systems. And what I mean is, number one, thyroid. There's a growing number of evidence, this one here in 2022, showing that the systematic review and meta-analysis of comparing thyroid hormone levels and cognition, dementia, and Alzheimer's in both directions. So looking at both directions to do with hyperthyroid and hypothyroid. And this study here in 2023, another meta-analysis and systematic review, looking at the hyperthyroid connection and dementia. So looking at the hyperthyroid, so Graves' disease potentially, and dementia, they found that in comparing a number of studies and thousands, tens of thousands of participants, to show that the relative risk is actually increased. And even when it comes to be adjusted for age, sex, ApoE status, and gender, as well as even region. And what they found was on average about 1.3 for a relative risk score of having dementia or getting dementia with a history of hyperthyroid or concurrent history of hyperthyroid. What's also interesting is that in the hypothyroid state, that there's actually a protective mechanism when it comes to dementia, which is quite intriguing to me. And I'll explain why in my next few slides right here. But even adjusting for cardiovascular health and for ApoE status, that most of the relative risk is less than 1, which is saying that when one has a hypothyroid condition, that they're actually potentially protected from risk or lowered risk of developing dementia. I thought that was really interesting because when you look at the pathophysiology and the biochemical factors when it comes to thyroid metabolism, that one, the thyroid hormone negatively regulates the transcriptional activity of the beta amyloid precursor protein gene, meaning that there is a connection and feedback mechanism to either induce or not induce the APP that we've talked earlier. But looking at this one study here in 2010, a little on the older side, but to show that hypothyroid actually induces the APP pathway in creating that insoluble beta amyloid plaque. But this most recent article here in 2024 is showing that it is bidirectional. It is showing that you can have some level of cognitive decline in both hyper and hypothyroid cases. And in reflecting a number of my cases with hypothyroidism, by correcting and optimizing the health of the thyroid, that they almost get this brain fog that's lifted. And that's why it just makes more sense to me that it is bidirectional in making sure that your thyroid is in that sweet spot. That's probably the best way I could describe it. Because thyroid is needed for a number of things when it comes to your brain. If your thyroid is dysfunctional, then that could lead to neuronal death, and especially with the synapse, so synaptic impairment. Thyroid hormones play a crucial role in the survival of the neurons and in the plasticity of the synapses. Thyroid is also needed to fold proteins appropriately. And by misfolding the protein, that's going to cause that insoluble, or the production of potentially insoluble plaque. And not just the plaque, but also tau tangles, which again is misfolded protein right there. Thyroid dysfunction can lead to oxidative stress, and that further exacerbates, there we go, neuronal damage, and contributing to cognitive functions and memory. And these all collectively can establish thyroid dysfunction as a potential risk factor for Alzheimer's disease and dementia and cognitive decline. Then there's also the hypothalamic pituitary thyroid axis as well with that connection. So of course, when I work with my patients, I want to make sure that I do test properly and thoroughly. And what I mean by thoroughly is not just TSH, but definitely free T3, free T4, and even the autoimmune, the autoantibodies, only because I have seen cases like this, where a patient would come in and say, well, my doctor told me that my thyroid's fine because my TSH is at 1.8. And so I retested this patient, and for sure, they were still at 1.8. But this was the rest of it. So T4 at 11.4, to me, a little on the lower side. I do like T4 perhaps approximately 14 to 16, but the T3 is actually really good. So that means for this patient here that they may not be producing as much T4, but they are converting enough T3 to be at 3.8. But that also means that the feedback mechanisms allow for TSH to be normal. But this patient here, going through brain fog, fatigue, but also symptoms of hair loss, skin changes, lesions, and itchiness, and weight gain and constipation, got me thinking and potentially screaming thyroid, even though the patient already claimed that there was nothing wrong with her thyroid, only because the doctors have tested her TSH. And so when I tested this and saw that both autoantibodies are elevated, we started correcting that, and eventually the brain fog lifted. Because I want to make sure that we are testing thyroid thoroughly. And TSH, not quite a function of thyroid, it's technically a hormone, thyroid stimulating hormone, that's made by the pituitary gland going to the thyroid. And well, this was another case of mine right here, where I have never seen TSH to be this high at almost 100. And through working with this patient, even though asymptomatic, there were still subtle signs of cognition there, likely because the T4 is definitely underproduced, and thus the T3 is not as well converted, or not converted from the T4 as much. But this is what we call macro TSH syndrome right here, where TSH is bounded to an immunoglobulin, and thus the size of it is so great that the feedback mechanism is not happening, and thus the brain is thinking that there is no thyroid hormone and is thus producing and overproducing TSH. Now, with macro TSH, normally you would see a extremely elevated TSH, but T4 and T3 tend to be normal in this case. So I thought this was interesting to show, because I don't think many of us do see this kind of thing. Even this was my first time seeing it. And I thought, wow. Besides thyroid hormones, there's estrogen and there is testosterone. And I think there is a huge gap in the role of estrogen and cognition. Now, with that being said, there's a gap in literature. And this paper, more recent, showing estrogen being the sex differences and the role of estrogens in the immunological underpinnings of Alzheimer's disease. There's a number of studies, not just this one, but estrogens on neuroplasticity and cognition. And this systematic review in 2024 is all showing a number of things where it's mixed right now, because there's still gaps about, is it really contributing to cognitive decline if you are lacking estrogen? This randomized control study in 2020, a systematic review, looked at 34 RCTs, and that includes almost 15,000 treated and almost 13,000 placebo, showing that for those that were induced menopause or surgical menopause, so full hysterectomy, that there is improved global cognition when there was estrogen therapy. But there was no change in the cognitive domain in those who did have naturally occurring menopause and were given hormone therapies. So there's still gaps about that, including timing, because we're all potentially taught that it should be within the 5 years of menopause to be initiating hormone replacement therapy. But then there's also timing about why not do it prior or whilst you're in perimenopause, for how long, what kind of forms. And also these kind of studies, the big gap with these studies is they don't account for other things that could also contribute to brain health and cognitive decline. But I do see that hormone therapy is going to be a really big thing, and it's going to be a big factor in brain health, because estrogen is one of the most powerful neuromodulatory hormones in the brain, and it's already been well established that its role in neuroplasticity in literature, including boosting synaptic growth, increasing the number and density of the dendritic spines, and especially in the hippocampus and the prefrontal cortex, which makes sense. You're going through, for women going through not just pregnancy and postpartum, but also perimenopause and postmenopause, a number of the symptoms include what we call mommy brain, short-term memory loss, and just unable to focus, as though there's that brain fog. And that's because of these two affected areas, the hippocampus encoding for short-term memory, and the prefrontal cortex really supporting our focus, concentration, and our executive function. Estrogen's also known to enhance synaptic transmission, enhancing cholinergic and dopaminergic signaling. Of course, we know that choline and acetylcholine is needed in producing and encoding for short-term memory. And that's where some of the medications, such as Aricept or Donepezil, which is an acetylcholinesterase inhibitor, is found to be in evidence supporting this aspect of the memory. Estrogen is also known to regulate BDNF, so brain-derived neurotropic factor. We need that as our fertilizer for the brain, and not necessarily just for the general part of the brain, but also for the hippocampus. Again, short-term memory. So I know that there's going to be more evidence, a growing amount of evidence out there And I know there's a number of naturopathic doctors who are doing amazing work in the hormone replacement therapy that I need to learn from as well in regards to dosing and such. And same thing with testosterone. For men, lower levels of testosterone has been associated with an increased risk of dementia, and some even saying as high as 2 to 3-fold, even up to 4. And this study found that a higher total testosterone level was linked to reduced risk of Alzheimer's disease, suggesting a protective role for testosterone in the male counterpart. But also, I would say that both hormones in general are protective. They are neuroprotective. And we need those hormones to help support our brain health. In this paper here in 2016, the neuroprotective role of steroidal sex hormones. So testing for hormones is an additional aspect in my work. I normally have 2 panels, and the first panel, that was part 1, and that was more of the preventative model. And looking deeper, I would start testing the thyroid enhanced, the female hormone assessment, and also testosterone, both the total as well as the bioavailable and free testosterone. There are some new tests coming up that is starting to grow in evidence, and I'm excited to find out about these tests and to be able to see them in my practice as well. This first one being neurofilament light chain, NFL. This biomarker, best for assessing traumatic brain injury, including concussions and chronic traumatic encephalopathy. And I find that one of the biggest contributing factors to our world of dementia happens to be trauma. And if you're familiar with the Bredesen protocol, it talks about the different types of Alzheimer's disease. One of them is trauma, type 4 or 5. But one of the 6 types, trauma, very big one. And we have a lot of programs in place in the healthcare field about assessment of concussions and assessments of traumatic brain injuries, and looking at symptoms, including cognitive decline, short-term memory loss, loss of focus, potentially quote-unquote attention deficit. But are there programs in place for reassessing and ensuring that one going through a program for their concussion or their traumatic brain injury is gone through completion? So there's not really testing involved in that, and I feel NFL is going to be one of those tests that will further assess and ensure that whatever one is being treated for concussions and traumatic brain injuries, that they are improving and that it shows in a biomarker. So what is NFL? NFL is neurofilament light chain, which is a protein released in the bloodstream when the axons of the nerves are damaged. So the levels of this can reflect the extent of neuronal injury. So it is a spectrum. So it's not just a positive or a negative thing. And we are always going through some level of damage and some level of kind of turnover. But it's about an elevated and an abnormal elevation of NFL that would then tell us and inform us that there is still more work that's needed to be done. And thus, this makes it a very valuable tool for diagnosis, prognosis, and monitoring recovery, which I've been alluding to. And elevated plasma NFL levels, so this is a blood test. So it's also very accessible, linked to faster cognitive decline and increased brain atrophy in neurodegenerative dementias. So I'm pretty sure we all know some level of, what are some good things for trauma and traumatic brain injuries, like omega-3 fish oils and magnesium threonate. Those are great. And I know this is not really a treatment talk right here, but when you're assessing, I think that'll also give you insight as to how you want to further treat your patients. So right now, there's current research primarily focusing on its role in diagnosis and disease progression. rather than direct therapeutic interventions to reduce NFL, I still think that it could be a direct way of reassessment and thus showing us how far one can actually get through in terms of their recovery and thus mitigating the risk of cognitive decline and dementia. And there's been some more recent and growing literature, this one here in 2024, plasma neurofilament light chain as a prognostic marker of cognitive decline in neurodegenerative diseases. So that's NFL. The other test is GFAP, glial fibrillary acidic protein. Now, this is an intermediate filament protein found in astrocytes, so the support cells of the brain. So these are the cells that kind of crawl around in between your neuronal cells, and they are to support those neuronal cells. And its expression of GFAP increases when these astrocytes are activated in astrogliosis. And the interesting thing about the astrogliosis and the astrocytes is that one of the cells, one of the only brain cells, or the only types of brain cells that do not technically regenerate. So once an astrocyte does get damaged, or the term here is called priming, when they prime, I think of like you get your dendrites and they prime so that their arms just reduce so that they become inactive. And when they become inactive, they stay inactive. And that's technically the hallmark also of the neurodegenerative diseases, because the astrocytes are then not able to function and to support the neuronal cells. So in Alzheimer's disease, the GFAP levels rise as astrocytes respond to the beta amyloid plaques and the tau pathology. In other words, the GFAP is also an indicator of suggesting neuroinflammation. So elevated GFAP reflects gliosis, which can then proceed to neuronal loss and cognitive symptoms if you don't slow down that priming of the astrocytes and the glial cells. And just evidence for your interest in regards to looking at the GFAP and NFL and actually detecting for preclinical stages of dementia. So these are things that can be detected with the early symptoms of cognitive decline, and also as general brain health for GFAP and for NFL. So what it would be important to know is, this is where your clinical history is going to be very important, is if your patients are coming in with a history of head trauma and or potential signs of neuroinflammation, whether that be uncontrolled brain fog or chronic brain fog, dizziness, syncope, and all that this could be one of those things that can be considered for testing after taking a thorough intake on brain health, head trauma, and cognitive domains. And the other test I'd like to talk about is ApoE, or apolipoprotein E. Apolipoprotein E is a gene. So it's a genetic test involved in the production of ApoE for cholesterol transport, lipid metabolism, and neuronal repair in the brain. And so there are 3 different alleles for ApoE, and that's ApoE2, 3, and 4. 3 is the normal. So if you have, and of course being genetics, you would have a pair, one from mom and one from dad. If you're with a copy of ApoE3, that's going to give you a risk of just 1. So it is normal. When you have an ApoE2, that is a protective factor. So your risk would actually decrease. And an ApoE4 is the allele that increases your risk. Now, FYI, this is a risk factor, risk assessment gene. So it's not necessarily a gene that is linked to Alzheimer's, but this is a risk factor for Alzheimer's disease, meaning one may have and can have ApoE4, and I'll show you an example later, but one could have ApoE4 and can still have their risk mitigated once you confirm what their ApoE status is. because there's now more literature about how you can approach ApoE status. So you can have different genotypes, 2-2, 2-3, T4, 3-3, 3-4, and 4-4. But carrying one E4 is going to increase your risk by about 3 to 4-fold, and having two alleles increases the risk of 9 to 15. Now that's in a more recent paper. I know there are some papers a number of years ago that showed and suggested that having one copy of the ApoE4 is going to increase your risk by 2 to 3-fold, and 2 copies 7 to 8-fold. I remember saying that for a number of years. And now just going through some of the other works and papers, I saw these numbers right here. And I thought, things are changing. And who knows, we might see in a couple of years from now that these numbers will change once again, because we're not sure about how many people do have the ApoE4 status and how many people are tested and how many people are confirmed. But this is very different from an Alzheimer's linked gene, just to educate you on some of this here. This being a risk factor gene. The other genes that can be tested, I think mostly through a geriatrician or a gerontologist, would be presenilin 1 and presenilin 2. So presen 1 or presen 2, and that gives you the direct link of Alzheimer's. And that would actually be linked to an early onset dementia, whereas ApoE is more a risk factor for late onset Alzheimer's disease, meaning those that may develop this in their 70s and 80s. But we need we need to know what ApoE contributes to, and mentioning about cholesterol transport, lipid metabolism, and neuronal repair, we're talking about if you do have the ApoE4, that there would be impaired amyloid clearance, increased tau tangles and pathology, chronic inflammation as a result of likely this dysfunction and metabolism or lack of metabolism of the lipids, and thus vascular dysfunction. So making sure that if you do have someone with the ApoE4, whether that be 1 copy or 2 copies, to always monitor their cholesterol. That would be their LDL. That tends to be always elevated. And there are associations of elevated LDL and dementia, and thus controlling it with supplementation, lifestyle, and work, and monitoring that tends to be the work along with ApoE, and also testing other things such as ApoB as well. But this one here in 2023 shows the ApoE4 and the Alzheimer's disease pathogenesis with the mitochondrial dysregulation or deregulation, and thus working with mitochondrial function. And this paper here in 2021, this is probably my holy Bible here of nutrition when it comes to ApoE4. There are some really good things talking about the different diets and even supplements. And one of the supplements that tends to be underlooked when it comes to ApoE4 is quercetin. So it's intriguing to see some of this evidence right here. But fish oils, quercetin, vitamin D, and even looking at insulin resistance. So besides LDL, triglycerides are going to be elevated, and triglycerides tend to be a reflection of insulin resistance. So in the remaining 10-ish minutes I have here, I'd like to show and share a few of my cases here in my practice. And starting with this one, I happen to have had this one just recent in the last 6 months. And it's been a pleasure working with this one, 91, now 92-year-old. So starting with them 6 months ago, 9 months prior to that, this lady was 91, now 92, of female Asian descent. She's a very petite lady. I would say she's probably about 4 foot, 4'9", 4'10", and quite underweight. But she was diagnosed 30 years prior, approximately 30 years prior, with diabetes, and has been on metformin ever since. And the reason why I remember this lady is she came in with chief concerns of short-term memory by her family, so brought in by her family, her daughter-in-law, her son, and even one of her other children, so another aunt of the aunt of the child, the grandchild. So what they said was she was forgetting everything. She would ask the same questions almost every 2 minutes, like, "Oh, when are we eating?" And even after eating, she would be like, "Oh yeah, so when are we going to eat?" And of course, of Chinese descent, she spoke primarily in Cantonese. And because of the Cantonese and my limited Cantonese, I was unable to do the mocha, but did note that there was quite a bit of short-term memory loss. But what was also associated with the short-term memory loss was this history of paranoia. And her family mentioned that she would have these moments where she would lock herself in her bedroom and would yell out in Cantonese that people are stealing from her. They're stealing her wallet, they're stealing her keys, they're just stealing everything, her money. And they weren't sure why, and she was put on a couple of things, antipsychotics. And it was quite intriguing to me, but I did her full array of testing and found a number of things. So let me just show right here. In September of 2024, she was also with a history of thalassemia. That's where you see the microcytosis and the hypochromia, besides the elevated iron and the elevated iron saturation. But what was important to me was the ESR being quite high at 28, and also looking at her blood sugar values, her insulin, I tested at 132. So that means she was at a HOMA-IR about, off the top of my head, 5 to 6. And her blood sugar, there we go, glucose fasting 10.2, of course elevated, hemoglobin A1C 7.8, so that definitely is diabetic. And so we worked with a number of regulating blood sugar and making insulin more sensitive. So I got her on a number of things, including berberine and lifestyle changes, including protein intake, protein before her carbs, and physical activity after. But what was interesting was I got them to do a diet diary and to also note not only what they're eating, what she was eating, but also if she was getting her symptoms of paranoia. And I noted that on days that she had more simple carbs, like fried rice or something like that, that she would have that event happening. So what got me thinking, and what got us thinking about getting this patient on a glucose, the continuous glucose monitor. And so we said, why don't we just try it for 2 weeks, see what happens, and get her going. And what was really intriguing was I got the report and found that she would actually have those paranoia attacks when her blood sugar was greater than 14. And that was intriguing to me. We started talking about making sure that we can blunt that blood sugar spike. And I don't think she's had any, if not maybe 1 or 2 attacks ever since we've controlled the blood sugar. I thought that was really intriguing. But I've worked with her for 9 months, and then just going over, and here's some of my treatment right here. We talked about supplementation, about inflammation, about insulin sensitivity, and physical activity, and we did that continuing glucose monitor. And we did follow up a couple times to adjust the doses. I'm not here to talk about the doses, but just to go back a little bit here, the other symptom that she was going through that I noted was she was quite talkative. She was still able to carry on a conversation, and we would talk, and she would speak to me in Cantonese saying, I read the newspaper every single day because it's good for my brain. And then I asked her, so what did you read today? Well, I read the newspaper, so it is good for my brain. And I thought, okay, so could this be anosognosia, denial? So I just kept that in my chart there. 9 months later, after treating her, look at her blood work here. 9 months later, in June of 2025, blood glucose at 6.4, whereas it was 10.2. HbA1c down to 5.3, and we were going from 7.8. So she went from diabetic to not even diabetic at this time. And her insulin going down to 45, which puts her HOMA-IR at just below 2. So I thought that was an extremely significant change in her numbers. And then when she came back in doing this blood work and going over this blood work, she came back and sat down and greeted me, and she said, "I read the newspaper every single day. It's good for my brain." And so I asked the same question to her. "So what did you read today?" She looked at me. She looked out the window, took a moment, then looked back at me, and she said, "I don't remember." The fact that she was trying and that she admitted was number one. But then she said something else afterwards, and that was, "But I do remember tulips." And the whole family that was with her in that visit all looked at her shocked and looked at me shocked. And they said, "We took her to a tulip festival yesterday." And I said, there you have it. So in this step right here with my patient, moral of this story here is working with things that are impacting the body to help the brain get enough fuel, because she was insulin resistant and technically inflamed. I didn't get to test GFAP, but her ESR is elevated. And in correcting the insulin resistance, she's able to get glucose to go to the hippocampus, which has more, histologically speaking, more insulin receptors than any other part of the brain. But now, even though she's getting the fuel, she now needs to induce it. So she needs to stimulate that part of the brain. She needs to start working on her short-term memory. And so she was working on it. So now I'm telling the family here, start asking her about her day, start asking her about getting her to try short-term memory, whether that be from playing cards, card games and such. And she'll start creating that neuroplasticity again. I don't know the context of how much that can be done, but the part here is I'm not here we can't really reverse dementia. It's about salvaging what we have left and be able to recreate and make new connections through neuroplasticity. Going to my next two cases here. Case study number 2, 67-year-old Caucasian male. And what initiated him to see me was when he was coming back to Canada from a trip. He was very apprehensive about leaving the plane and not remembering where he was. And after that incident, there wasn't really much following after that. So there wasn't really much known about that, but then driving habits have been quite concerning and has had him resulting in doing another driver's test and then having him get downgraded to a learner's license at this time. But he is growingly, after working with him, able to perform his activities of daily living. He's able to speak, and some difficulties of word finding, but wife claiming that this happens approximately 3 times a week, but no confusion with time or space. And in doing, first off, the routine blood work that I like to do, B12 being low, insulin being elevated, I'm just going back through here. Glucose was slightly elevated, HbA1c 5.7. I think we're getting into the new guidelines now that 5.7 is the borderline of pre-diabetic rather than 6.0. And insulin being 122, so he is at about the 5 to 6 HOMA-IR range. And homocysteine to me was also very elevated at 12.4. And I do want that to be between 5 and 7. So in working with them, we've done some supplements to support the insulin, to support the B vitamins, and getting them on the ketogenic diet. What I remember about this patient so well, I love stories, but the wife was like, well, it's just steak and red wine, right? But it was the ketogenic diet that really got him going into this positive trajectory of retesting mocha and getting that to be increased from 8 out of 30 to then 21 out of 30. So I can't stress enough the importance of reassessment and looking at how these can be involved in working with assessments and improvements. And I know I just have a few minutes left, so just wanted to touch base on this one right here. 69-year-old female. I've been working with this lady for about 3-4 years now. And she came in wanting to mitigate her risk of dementia because she has both parents with dementia. And her MOCA test was 28 out of 30, which was really good. Not early insulin resistance, but she is a carrier of an ApoE4. So that means her risk of developing late onset Alzheimer's disease is increased by about, my old numbers being 2 to 3, now being about 7. And looking at her blood work from 2021 onwards, blood sugar was borderline, of course, now we call that pre-diabetic. It's her cholesterol that we had to monitor, because when you carry the ApoE4, the LDL will have a tendency to rise, and there's this correlation behind LDL and development of dementia, and even triglycerides. And I want to make sure that both of these numbers were maintained as much as possible. So in working with her over time, and homocysteine, that's her cardiovascular health that I tested, we want to make sure that we optimize that to be about 7. So in working with her, we've actually improved her cholesterol, her triglycerides. We even tested for ApoB and want to keep that as low as possible. LDL has gotten low. But what's really intriguing is even working with a preventative case, she did mention about how she was feeling a lot more sharper. Not that she didn't mention anything about brain fog, which was interesting to me. So working with these things can still seek improvement in a number of factors. Now, things will fluctuate. So we are getting to this, like this is just 0.03 above, but I know patients don't really like seeing the A and the flag right there. So it's a dance right now. And for this patient here with the ApoE3/4, I'm having her come see me at least once a year to get tested, whether that be not the weather, but with cholesterol and ApoB. But of course, we're getting a number of things, especially this big one here is the quercetin. After my research with the paper by Norwitz about ApoE4 status and nutrition. But we're also looking into building habits, improving insulin resistance, getting sleep to be better. Those are all things that we are working with, and just on a yearly basis. So she'll come back and report about how she's feeling and what her next step would be in terms of building her habits. So just to summarize right here, I'm just right at the hour. Dementia doesn't start just in the brain, it starts in the body. And this is where we look at the body biochemical factors to give us insight on the landscape of the brain, and screening with a number of these panels can be an integral part of prevention and brain optimization, regardless of where your patients are at in terms of their staging of cognitive decline. That's what I like to refer to the term as cognoscopy, as mentioned by Dr. Dale Bredesen, that maybe since we get the colonoscopy at age 50, could we also look into making sure that we optimize these factors as a part of our brain wellness, especially later in life. I thank you for your time and for taking the time to come attend this in the morning, in the earlies in the morning. If you have any questions, feel free to put them in the chat box. I am also open for questions. Feel free to reach out to me at my email or my social medias, and I'd be more than happy to chat and discuss and even consult when it comes to dementia cases. And lastly, before I interrupt Tina, thank you, Tina, and thank you, Life Labs, for having me.
It's a pleasure. We enjoy having you, Dr. Fung. I know there's a couple of questions. Some of them already been answered about the webinar part 1 that will come on our recording for part 2. So that will take about a week. We download and clean things up and we'll submit then. But I do want to address, if we have 1 more or 2 more minutes to go, how do we order these tests? I want to let you know that these tests will be launching in about a week's time when we send out the webinar recording, and there will be a special requisition required, and that requisition you will need to utilize and submit for running these tests. It's not going to be added onto the other in your other section of your Life Labs requisition, your ND requisition. I do have one question I want to address, and that is on the GFAP inflammation. Just wondering about, would it also be good for stroke patients?
Absolutely. GFAP is not just meant to be for cognitive decline. I find, and this is just in the context of cognitive decline, hence the topic of this talk here, but GFAP can be very insightful for anyone to do with neuroinflammation. So that includes things like vascular incidents and stroke, things like I have one patient I'm considering right now with photophobia, so very sensitive to light. So anything to do with potentially the brain fog, and brain fog that's not improved with optimizing B12, iron, and thyroid can be a good measure to look into GFAP as well. So absolutely, right. And even trauma is also going to be a factor too, because once you get the traumatic injury, that's also going to be inflammation there.
Perfect. I just wanted to make sure I noted that. And then I'm just going to check and see if there was any other questions here added here. I know there was one about, yeah.
I appreciate it.
Can you read some of these already? So again, the slides, they're attached here, and part 1 webinar will be attached. It says here, what is your optimal for TSH on elderly?
Optimal for TSH. So functionally speaking, I like TSH at 1 to 2, but as you probably saw with my example, even though the TSH was in an optimal level, that when I tested further, found elevated autoantibodies, both thyroperoxidase and thyroglobulin antibodies. So TSH alone may not be a good factor just to say an optimal level of 1 to 2. I would simply go further if I can, and especially if your patients are exhibiting signs and symptoms of thyroid.
Perfect. Appreciate that. And I think I've addressed all the other questions here. I just got a pop-up saying that maybe the survey, the questionnaire to put in for the gift certificate for the secret words, it may come up after the recordings finish. So this is maybe why you're having glitches to submit them. But if there isn't any further questions, I want to say thank you again, Dr. Romi Fung, for being a part of our webinar today. And thank you again for being so patient. We were going to have this webinar earlier in the fall, but it was good that we waited because GFAP was added. So waiting for patients, we got an extra marker. And if you have any other questions, you can reach out to either Leanne or myself in BC for any help or further questions on the webinar today or any of the other biomarkers that were discussed. Thank you so much. Really appreciate.
Thank you so much.
Bye for now.